Welcome back to our Hypoglycemia series. In part 3, we'll focus on hypoglycemia unawareness. Hypoglycemia unawareness and the vicious cycles of autonomic failure. Just imagine a patient with diabetes who no longer experiences the typical warning signs of low blood sugar. No shakiness, no sweating, no internal alerts. As highlighted in our earlier session, those early hypoglycemia signals are missing, leaving the patient unaware of the risk. This silent danger is called hypoglycemia unawareness, and it's more than just a symptom. It is a signal that the body's defenses are failing. Now let's go now to the pathophysiology of hypoglycemia unawareness. Now hypoglycemia unawareness develop when repeated stressors such as intensive glycemic control, prior severe episodes, long-standing diabetes, alcohol intake, exercise, renal failure, or sepsis disrupt the body's normal defenses. The brain adapts to lower glucose levels and delays symptoms recognition, while hormonal counter-regulation with glucagon and epinephrine becomes blunted. As a result, patients lose early warning signs like shakiness or sweating and may progress directly to confusion, seizure, or coma, making this condition especially dangerous. Now, this is the concept of dampened hormonal hypoglycemic counter-regulation after recent hypoglycemic episodes. Now, repeated hypoglycemia weakens the body's natural defenses. Normally, hormones like glucagon, epinephrine, and growth hormones rise to correct low glucose and trigger warning symptoms. But after prior episodes, this response becomes blunted, a process called dampened counter-regulation. Over time, hormone release decline, making hypoglycemia harder to detect and more dangerous, often leading directly to confusion, seizure, or coma. Clinically, even mild repeated episodes can erode awareness, highlighting the importance of prevention and vigilant glucose monitoring. As shown in the diagram, that after the first, second, and third episodes of hypoglycemia, the secretion of counter-regulatory hormones such as epinephrine, glucagon, and growth hormone progressively decreases with each successive episode. So, how do we define hypoglycemia unawareness? Hypoglycemia unawareness is a condition where a patient fails to perceive early symptoms of low blood sugar. Now, what is the cause? It's often triggered by repeated hypoglycemia episodes, especially in patients on insulin therapy. What's the risk? It leads to delayed treatment and increases the likelihood of severe hypoglycemia. But hypoglycemia unawareness doesn't occur in isolation. It's part of a broader syndrome called hypoglycemia associated autonomic failure, or abbreviated as HAAF, a self-reinforcing cycle that compromises both hormonal and symptomatic defenses. The diagram depicts two situations. In the first, the patient experiences early warning signs of hypoglycemia, such as tremors and sweating, shown in the left and right cartoon images, which trigger timely correction of low blood glucose. By contrast, in the middle illustration shows a patient with hypoglycemia unawareness who does not develop these early symptoms and is therefore at greater risk of neuroglycopenic consequences, including confusion, seizure, and coma. Now let's define what is hypoglycemic associated autonomic failure, or HAF. It is defined by two key features. First, the body's counter-regulatory hormones responses become impaired, especially glucagon and epinephrine, which normally help raise blood sugar. Second, patients develop hypoglycemia unawareness. They stop feeling the early warning signs of low blood sugar. Together, These changes make patients more vulnerable to severe and recurrent hypoglycemia, often without symptoms. Recognizing these features is critical for preventing dangerous low and adjusting treatment safely. Now, the summary of the vicious cycle of hypoglycemia associated autonomic failure. Number one is recurrent hypoglycemia weakens the body's defenses, impairing hormone response like glucagon and epinephrine. This leads to reduced autonomic signals and hypoglycemia unawareness. Patients no longer feel warning symptoms. Without early detection, severe episodes become more likely, reinforcing the cycle. Breaking, breaking it requires vigilant monitoring, therapy adjustment, and of course, education. Understanding hypoglycemic associated autonomic failure is critical for safety and survival. In the diagram, you see two pathways of hypoglycemia unawareness. Recurrent hypo, often from insulin therapy, weakens the body's defenses, triggering HAAF. These unfold via two routes: physiological pathways, reduce autonomic signals, and blunted hormones responses. That's glucagon, epinephrine, that leads to hypoglycemia unawareness. It could be also psychological, behavioral pathway, emotional fatigue, and altered behavior also results in unawareness. So both paths converge on the same risk. The body stops warning you. Without symptoms, severe hypoglycemia becomes more likely, reinforcing the cycle. Breaking it requires education, therapy, adjustment, and early detection. So the key points is that hypoglycemic associated autonomic failure is most common in type 1 diabetes and in long-standing type 2 diabetes. It is triggered by recent antecedent hypoglycemia that can also occur during sleep or after exercise. The cycle is self-reinforcing: hypoglycemia, blunted response, unawareness, and then recurrent hypoglycemia. Now, this schematic illustrates defective glucose counter-regulation and hypoglycemia unawareness, unified under the concept of hypoglycemia-associated autonomic failure in type 1 diabetes as described by Cryer et al. And also seen in advanced type 2 DM. With each hypoglycemia episode, the body epinephrine response becomes progressively blunted. This impaired counter-regulation raises the risk of future hypoglycemia many times over. And over time, patient may develop hypoglycemia unawareness, losing the usual warning signs and symptoms. The result is a vicious cycle of recurrent hypoglycemia. Now, this table highlights on how sleep and exercise act as antecedent triggers that weaken the body defenses against hypoglycemia. During sleep, the brain's awareness of falling glucose is reduced and the adrenomedullary response is blunted. As a result, epinephrine release is delayed and symptoms are less intense, making nocturnal hypoglycemia harder to detect. In contrast, prior exercise increases glucose uptake and elevate cortisol as well as catecholamines, which temporarily desensitize the autonomic system. Epinephrine release is attenuated and muscle continues to absorb glucose even after activity, leading to delayed hypoglycemia, often overnight. Now, together, these factors explain why both sleep and exercise can blunt autonomic signals and contribute to hypoglycemia associated autonomic failure. So, I like to highlight these interesting articles in 2022 review by Bernstein and Moller in the Journal of Endocrine Society examines hypoglycemia associated autonomic failure in humans. It highlights how recurrent iatrogenic hypoglycemia in insulin-treated diabetes that leads to blunted counter-regulatory hormones responses and hypoglycemia unawareness, dramatically raising the risk of severe hypoglycemia. Now, this article synthesizes decades of experimental work, critiques, methodological limitations, and call for improved models to better understand hypoglycemia associated autonomic failures, mechanism, and clinical implications. Now, these two threshold charts illustrating physiological response curves that are also adapted from the Cryer's article is a summary of visualizing hypoglycemia associated autonomic failure through glycemic threshold. As you can see on top, which is normal, that illustrate the body's normal defenses against falling blood sugar, insulin suppression, sequential hormonal release, glucagon, catecholamine, cortisol, growth hormone, and autonomic symptoms and progressive cognitive decline. In contrast, the bottom panel depicts hypoglycemia associated autonomic failure where early defenses are absent, no insulin suppression, no hormonal surge, no warning symptoms, leading patient directly into neuroglycopenia without alert. Bernstein and Moller experiment confirmed this pattern. Antecedent hypoglycemia blunts both hormonal response and symptoms awareness, making insulin-treated individuals several times more vulnerable to recurrent and severe hypoglycemia. Their study also exposed key limitations in the current experimental design, underscoring the needs for standardized protocols to better understand and manage hypoglycemia associated autonomic failure in clinical practice. So let's summarize the concept of hypoglycemia associated autonomic failure. So hypoglycemia associated autonomic failure describes a breakdown in the body's normal defenses against low blood sugar. Instead of reducing insulin and releasing these counter-regulatory hormones like glucagon and epinephrine, these responses become blunted. Warning symptoms such as sickness and sweating disappear, and patient may progress directly to confusion, seizures, or coma. Now, the experimental studies that we mentioned in this presentation show that prior hypoglycemia can silence these defenses, creating a vicious cycle of recurrent severe episodes, which highlights the need for standardized protocol in research and clinical care. So the clinical takeaway, one is the recognized high-risk group. These are patients on intensive insulin therapy, patients who have frequent hypoglycemia, and in long-standing diabetes, as well as in elderly patients. Now, we need to prioritize education, therapy adjustment, and early detection to break the cycle. With those clinical takeaways, we now bring part 3 of our hypoglycemia series to a close. The next installment, which is part 4, the prevalence and clinical impact, as we will shift our focus from mechanism and vulnerability to understanding how common hypoglycemia and hypoglycemia unawareness and the real world consequences they carry for patients and clinical practice.